Welcome to Health Talk. I'm Dr. Gloria Wu, and I'm your host. This is we're going to talk about menopause and bone loss. Today we have with us Dr. Maureen Khoo. She's in private practice, obstetrics and gynecology in Los Gatos. So today we're going to talk about menopause. Welcome, Maureen. Tell us, what is menopause?
Natural menopause is defined as cessation of period due to loss of ovarian function. Most women experience menopause between the ages of 40 to 58, with the average age being 52.
Now, usually that time period, people are always talking about hot flashes and other symptoms. What are the other symptoms besides hot flashes?
There can be a wide variety of symptoms. Most common are hot flashes and vaginal dryness, but you may also experience mood swings, insomnia, depression, or decreased libido.
About the hot flashes, for some women it occurs every day, and some people occurs during the daytime, some people occurs at night. Tell us, what is it that brings them to your office?
Most women complain of hot flashes at night, but you may also experience during the day.
And that we were talking before we got on the set that some of these ladies, depending on their socioeconomic status and their ethnicity, they have different experiences with hot flashes. Tell us a little bit about that.
Again, hot flashes is something that we have not been able to actually quantify, or there's no. It's difficult because of variation in ethnicity and socioeconomic status.
Or to really quantify, because some people may complain more and some people
Exactly.
really don't say very much about it.
Right.
And then when people also complain of mood swings, the mood swings, how bad can that be?
Well, it can be pretty bad at times, and it could be as severe as going through a major depression.
And then, so some of the treatments I hear are geared towards that. Like, for example, they have antidepressant agents, Effexor or something, which also help a little bit with hot flashes. Tell us a little bit about that and how that has been in your practice.
It's not really a first-line treatment for hot flashes. The most effective treatment for hot flashes is the hormone therapy. With estrogen alone, or in combination with the progestin for a woman who still has the uterus, to prevent uterine cancer. If you cannot take hormone therapy for some reason, then there are alternatives that you can consider, like herbal remedies or antidepressants. But again, the alternative therapies have not been shown. There's not enough study to evaluate the safety and efficacy of those therapies.
Now, some of the alternative therapies, one of them is black cohosh. Tell us a little bit about that.
Well, it's a herbal compound, and again, because it's considered a supplement and not a drug, so it's not regulated by FDA. And because of that, the different batches of the compound can have various dosages. That's why it's been difficult to evaluate the efficacy of these products. You also need to be very careful when you're taking those herbal therapies, because some of these compounds can be harmful to you if you take in excessive quantities. Like it can cause liver dysfunction or abnormal liver enzymes.
Also, it's important that even though they're taking herbal therapies, they see a physician like yourself to make sure that they don't have other side effects.
Right. You have to consider, your medical history. If you've had history of liver disease or hepatitis, then it's not recommended that you take black cohosh.
And soy has been thought of as a remedy also. Soy milk, tofu.
Right. Soy belongs in the class of compounds called isoflavones. They have some estrogen-like properties, so they've known to help with hot flashes. Again, we don't know the safety of these products. For example, we know with the Women Health Initiative studies in 2002 that estrogen in combination with progestin in postmenopausal women can have increased risk of invasive breast cancer. So again, with these products, if you take in excessive quantities, we don't know for sure if it's going to cause breast cancer or uterine cancer. There's not enough study to conclude that.
Now, the Women Health Initiative, after they came out with their results, there was a big drop in estrogen use. And now they have new publications that tell us what to do. What are the latest you were telling us?
Well, the current recommendation is that if you really need to take estrogen, considering you don't have any risk factors like any personal or family history of breast cancer, then you can consider taking it, but start with the lowest dose and take it for a shortest shortest period of time as possible. The studies show that after you take it for 4 years, the risk increases. So I would try to take it, 3 to 4 years or less than 4 years, or even less than that if you can. Sometimes you can take it for just a year and just slowly taper it down to see if your hot flashes subsides.
And then for those women over age 65, there seems to be that hormone replacement therapy is not recommended. Is that right?
Well, the Women Health Initiative study also found that in addition to increased risk of breast cancer, there's also increased risk of heart disease, stroke, blood clots,
and Alzheimer's.
And especially, dementia, especially in women older than 65-year-old. So we're not recommending for women over 65 years old to take hormone therapy.
Now, in the latest for these recommendations, there's still need for people to take estrogen simply because the hot flashes are so profound that it affect their lifestyle, so they need to take them.
Right.
And some women, these hot flashes go away after a certain time. Tell us a little bit about when women can expect that to go away. And
most commonly, the first 2 years after menopause, about 80 to 90% of the women would experience hot flashes. Then after that period, about 60% of them will feel better. They won't feel as frequent hot flashes or no hot flashes at all. But there is still about 50 to 60%, about 40 to 50% of the patient after 5 years, the hot flashes still persist.
So for those people, after age 65, there's like almost no hope. They have to do something else. So what do we do for that group? 65 and beyond, they still have the hot flashes. Do we tell them to do what? What do you guys recommend?
After 65-year-old? Yeah. Again, there's the alternative or herbal medication. As long as you don't use it too excessively and there's no contraindication like other medical problems involved, you can try those. Or, other medication like antidepressants called Effexor sometimes can help with hot flashes.
Now, the other symptoms of menopause, you have the vaginal dryness. That seems to be taken care of if you use KY jelly or Premarin cream. And so is that effective for the women experiencing these symptoms?
Yeah, the local treatments for vaginal dryness, like vaginal cream, tablets, or even like some flexible vaginal rings, you can use that. As long as you don't use it over a long period of time, there's no increased systemic absorption of those estrogen compounds. They do help with vaginal dryness, but they're not shown to help with the hot flashes.
And then about the loss of skin tone, the dermatologic reasons of, sequela of
Right.
menopause. I'm sure that's why there's a rise of all these makeup creams, collagen, anti-wrinkle. And
Well,
so that wouldn't help them on other parts of their body, right? The Premarin cream.
unfortunately, the Women Health Initiative study did not study the cosmetic effect of the menopause and the effect of estrogen. So I would say, there's no study yet, to consider the cosmetic effect of that.
Now, in menopause, most people come to you mainly because of the hot flashes. Is that what their major problem is? Is that what causes them to come?
Actually, there are quite a number of women who also complain of mood swings and depression. And in my experience, putting them on hormone therapy really help with the mood swings, and especially with the depressive symptoms too.
Now, in the perimenopause, the year before they actually have cessation of their period, those ladies, they also come in because there's breakthrough bleeding and all that. What do you give them?
Yeah, if you're in the perimenopausal period, that means your period hasn't really stopped completely. A good way to treat is to put them on a low-dose oral contraceptives. And that will give them a more regular cycle, more regular period, and also would help them with the hot flashes, also improve the, will decrease the rate of bone loss with the, some supplement of the low estrogen in the oral contraceptives.
Now, estrogen helps with bone formation. So as there's menopause and at age 40 when people naturally lose bone anyway. So together, that's why women are at risk for bone loss, osteopenia. Now, tell us a little bit about that age group at age 40. What happens to bone formation, and who is at risk?
Yeah. Well, your bone is a living tissue. It's always breaking down and building up constantly. And most people reach their peak bone mass at age between 20 to 30s. And after 30s, you start losing bones. And definitely when you're in your 40s or 50s, the rate of bone loss increases, especially when you're in also when you're in the menopause stage. There's loss of estrogen, which is critical in building bone and maintaining bone. So, certainly if you take hormone therapy, studies have shown that it increases bone mass and prevent fractures, prevent osteoporosis.
So the people who are at risk for bone loss, or osteopenia, osteoporosis are Caucasians and Asians, and what other risk factors?
Yeah, if you're Caucasian or Asian, you are at increased risk of osteoporosis, and also if you have family history of osteoporosis. If you're on certain medications for a long period of time, such as steroids that are used to treat arthritis, and also if you have certain medical condition like thyroid problems, you're at risk of osteoporosis.
Now, in the definition of osteopenia and osteoporosis, you have a nice model. Show us what that means.
Well, your bone, if you look inside, it looks sort of like a honeycomb appearance, and osteopenia is defined as there's decreased bone density. So the spaces in the honeycombs get greater. And with osteoporosis, though, the spaces got even larger, and also the bones that are making up these honeycombs are softer and thinner. So that predisposes you to increased risk of fracture.
And collapse, like in this model, where you have this actual disc and vertebrae collapsing. So that's how people lose their stature, and you get the dowager's hump, where our great-grandmothers walked around with, you know, a hump
Exactly.
on the back.
Right.
And now we see that less and less, but this is what happens with loss of bone. Now,
Right.
there's now wonderful testing. Tell us about the testing.
Well, there's a bone scan or bone density testing called the DEXA scan, and it stands for
Oh,
you
dual
can-
X-ray absorptiometry.
Exactly. It measures the bone density in your wrist, hip, and your lower back or low spine area. And we do have a criteria that we use for osteoporosis and osteopenia. There's a score called a T-score. If you're between minus 1.5 to 2.5, it's defined as osteopenia. And if you're greater than minus 2.5, then it's defined as osteoporosis.
So osteopenia is some bone loss, and osteoporosis is severe bone loss.
Exactly.
And so here, if you had osteoporosis, this would actually collapse, and then you have also risk of fracture. Oh, and that's why they tell ladies who are at risk to not drink alcohol, because they might fall.
Exactly.
And also
Right.
smoking, no smoking.
Right.
Because-
Smoking accelerates the bone loss.
So another reason not to smoke.
Exactly.
And then the DEXA scan is done every other year or every year for people with osteoporosis?
Well, it depends. If your initial one is normal, you can do every other year. But if you start out with severe osteoporosis, then after treatment, you might want to do another DEXA scan in a year just to see any improvement.
So in the DEXA scan, where they just sort of look at your wrist, it's painless, and what happens is that you have two sources of X-ray. They go oscillate back and forth, and by computer they figure out how much calcium there is, and how much calcium is causes a different image on the screen. They figure this T-score. This scan, do people start doing it at age 40? Do women, or what age they suggest that women start having this DEXA scan?
I usually start with when they, menopause.
So 50, 52, around that time.
Exactly.
And now, can they follow changes on the DEXA scan? Like when they see one, they compare it to the previous one?
Right, you can. Like I said, after treatment, you can do another bone scan in a year to see if there's any improvement. And if there is, you can, go for another 2 years and then do another scan.
Now, the treatments, tell us a little bit about the treatments for, osteoporosis.
Yeah, there are a number of medications available. If you're not a good candidate for hormone therapy, there are a number of medications available for you to take. There's alendronate or Fosamax, or Risidronate or Actonel. These are the drugs that fall into the category called bisphosphonates. What they do is they decrease the rate of bone breakdown and increase the buildup of the bone.
And they do have side effects. People complain about drinking lots of water, having standing upright, esophagitis.
Exactly, yeah. You can have heartburn or stomach pain, or in severe cases you can develop ulcer.
And now it's once a week. You can take Fosamax once a week.
There's also a new one that you can take just once a month.
Boniva.
Right.
Right. And these are all rather expensive, so they're probably like $160 a month.
Right.
But it's worth it since we don't want to have, the dowager's hump and all
Right,
that.
exactly.
Now, for women who already have osteoporosis and they take Fosamax, has there been studies to show that there's improvement in their?
Oh yeah, definitely. They've been approved for the treatment of osteoporosis and preventing fractures. So those are the two classes of drugs that I mentioned, and there are also other drugs like called Evista or Raloxifene. That's the drug that has activity similar to estrogen, but not quite an estrogen molecule. and that has been shown to also prevent osteoporosis. There's also calcitonin, which is a hormone which regulates calcium in bone metabolism. It's a nasal spray that you use, and there's also a parathyroid hormone that you can use. So those are the newer medications.
Now, for women who are in our audience, obviously starting at age 40, they should be taking how many milligrams of calcium a day?
Well, it's recommended 1,200 to 1,500 milligrams of calcium with vitamin D.
And how much vitamin D?
400 international unit. And if you're over 75 years old, you need 600 international units.
So the calcium could be calcium gluconate, which is Tums, or calcium.
There's calcium citrate, calcium gluconate.
Yeah. And now there are a variety of candy-like calcium supplements, chocolate-covered calcium supplements, Bioactive and CitroCal. And so do you find that what we've learned from the Women's Health Initiative in the last 15 years, it's really added to our knowledge? Because when I went to medical school, we didn't know that this was all the recommended dosages.
Well, it certainly helped us in guiding our, the direction and our decision on whether or not we should use hormone therapy and if there was any risk factors involved with it. So we should definitely just, tailor the therapy towards each individual woman. It shouldn't shy you completely away from using hormone therapy because of the increased risk of breast cancer and stroke and all that. But if you really need to, you can still use it for a short period of time with the lowest dose available.
Now, in the current studies where they show people take the vitamin D and the calcium, have they found that they had decreased risk of hip fractures and all that if people treated and not treated, or treated with estrogen and not treated?
The calcium and vitamin D alone?
Yeah. Or do they always did that in conjunction with estrogen hormone replacement therapy when they did the studies?
Yeah, they always do that in conjunction with the estrogen.
And then when they found out the estrogens did prevent hip fractures.
Definitely.
Over long term.
Right.
It's just that they found out in addition there were these other factors of heart disease and breast cancer. Now, for most women in your practice who are in the menopausal age group, after they've been treatment with you, either with hormone therapy for a year and their hot flashes go away, then you gradually wean them off the estrogens. How do you wean them off the hormone replacement therapy?
It depends on an individual, and it also depends on each individual's severity of hot flashes initially. You can try to wean them off by have them take every other day instead of every day for a month, and then the next month you can do, every 3 days, and then just gradually wean off that way.
And now some of these ladies also come to you probably because loss of libido, and for those people use some sort of combination of estrogen and testosterone, right? So tell us a little bit about those new therapies.
Well, I think the study regarding the use of testosterone in combination of estrogen is not very conclusive. Some studies show some improvement in libido, but others didn't.
And they have a pill called Estrotest?
Exactly. That has a combination of estrogen and the testosterone.
But it's not 100%.
Right.
And then some people use testosterone
There's
alone?
testosterone cream also, or testosterone alone in pills. Again, I think these need to be studied more in detail, like, maybe do another large study like a Women's Health Initiative with the prospective randomized control studies.
Now, testosterone alone can also has problems if you gave that to women. Doesn't it have risks?
Well, I think if you take testosterone in excessive amount, you also have increased risk of bone loss.
So then that wouldn't be back to the dowager home.
Exactly.
Okay. Yeah. So for our take-home lesson for our home audience, what do you want to tell our home audience? What's our take-home message?
Well, If you're in the menopause or perimenopausal stage, make sure the most important thing is you have a healthy lifestyle. Eat well, balanced diet, lots of fruits, vegetables, and fibers, and have weight-bearing exercises like jogging, running, even dancing 3 to 4 times a week. Take some calcium supplements, 1,200 to 1,500 milligrams a day with vitamin D, and avoid alcohol and smoking.
So smoking is, again, bad.
Right.
And so here in California, wine country, we have to be careful.
Well, you can have some alcohol, but, you know, not excessively. But definitely not smoking. You know, in addition to accelerating bone loss, it has other, you know, health risk involved with smoking. So.
And also, if you're going to take the herbal supplements, to see an obstetrician gynecologist for follow-up, because obviously they're the liver manifestations of the side effects.
Right, right.
And just don't take it excessively. And soy, as an estrogen, has also potency that can increase breast cancer risk. So they too still have to check in with you.
Right.
And not just take it and not tell anybody.
Right.
So the other thing to tell people about is that they have to start thinking about bone loss starting at age 40.
Exactly, because osteoporosis is a silent disease. You may not know it until you have a fracture. So you know, if you do have one of the risk factors, or you know, one or more of the risk factors that I mentioned earlier, definitely do a bone scan early and
see an obstetrician gynecologist.
Exactly.
So we're running out of time. Thank you so much for joining us. And I hope everyone will join us for Health Talk again, and call us if we have any if anybody has any questions. And we hope that you'll tune in again. And this has been on menopause and bone loss. And this is Dr. Maureen Khoo with me, and I'm Dr. Gloria Wu. Thank you for joining us on Health Talk.